back for another one, podcast 116. Some of you will be joining us for a second time this week. We were doing another online CE class last night, adding to our library of classes over at Chiro Credit and Online CE. We did this one on torsions, and you had a good idea. Thought we would talk about some of those things. My fear is that stuff is conceptually difficult without pictures. So what we did this week, in fact today, on November the 18th, is we put up 2 photos in a Facebook post. We're going to put it over on our blog as well, on thegateguys.com, and pictures of anti and retro torsion with feed in and feed out. You may want to pull those up, or at least get yourself familiar with those for this podcast. They may help you, because this is a difficult topic on a good day with lots of photos in front of you. So we'll see if we can fudge it down to something palatable, but who knows. So for those of you not familiar with those topics, this could be a little bit of an earful. But nonetheless, we're here to do our best, and we've got some good, neat updates on some things. Back many dozens of podcasts ago, we did a health intro on the gene editing thing called CRISPR. And I'll try and dig up which podcast that was. It was probably around 80 or 70 or something like that. And there's some new news on CRISPR in the literature here, actually in science. And it was kind of neat. What'd you think?
I thought it was pretty cool. For those people that need a quick little CRISPR lesson, CRISPR stands for Clustered Regularly Interspaced Short Palindromic Repeats. Palindromes, remember, the same when we read them one way or the other, but basically these are segments of DNA in prokaryotes, so in other words, bacteria without a defined nucleus in there. And what we're able to do is they have these short repetitions of sequences of bases, and then these little spacer proteins. And we're able to actually, well, not we, Sean and I, but people are actually able to utilize this particular gene with that spacing segment to be able to snip out or selectively edit the genome. And for the first time in this particular study here, this was done in China. Just really recently, like last, week or so here, where they tried to use the CRISPR technology to turn off a gene in people that have a small cell lung cancer. So we'll see how it goes the first time that this has been actually tried on humans, for obvious reasons, but looks fairly cool and fairly promising.
Yeah, this is the United States isn't far behind, according to this article. They approved this back in June for United States studies, but we all know that stuff takes, maybe on a good decade, 5 years, but may take 10 years before it's actually applicable to more people. But and that's certainly if it is a positive thing. But here they manipulated the cancer cells and the immune system by taking the T cells and changing the way the cell programmed cell death protein, the PD1, which normally suppresses a T cell's drive to eliminate cells. And so we'll see what it does. But these people already have cancer, and they have failed all traditional cancer models. So I'm not sure how it will work when someone already has the cancer. It'd be nice to actually clip that protein out and the problems out for the cancer prior to getting it. But in this case, the person has cancer, and they're trying to actually change the cell death protein in the T cells to try and change the response or the multiplication of the cancer to targets. So we'll see what happens here. It's going to be interesting. But here we talked about it, and here it's coming to fruition. And we've got a couple other little things that are starting to come to fruition, things that you and I have talked about on many levels, and again coming true here. We've been talking about bionics and brain implant, chip implants and stuff like that. And here we are, for the first time, a wireless brain implant has enabled paralyzed primates to walk again. And this was in Science Alert. We'll have it in the show notes. But this is basically a Wi-Fi technology for spinal injuries. And they basically are, let's say you've got a cord transection at, T1, T2 in the thoracic spine. Basically, what they do is they're mapping the brain in the cortical regions for the motor cortex, and basically they are circumventing that with a chip. So the normal cortex would send a message down the spinal cord, but in this case it's sending the message to a chip that's implanted in the brain. The chip then wirelessly transmits to a computer. The computer then wirelessly transmits to the electrodes in the lower limbs. And so you're basically just, through a Wi-Fi signal, circumventing the lesion in the spinal cord. And these primates were able to walk. And that's kind of it in a nutshell. You can go to the article and read a little bit more about it. But this is going to be a way of getting around a lot of problems for a lot of folks here. And it appears to be fairly logistical and possible. Any thoughts on this one?
First of all, I would encourage you guys to go to Science Alert and look. There's a quick little video on there. It's 2 minutes long with the professor that's been talking about this, and it's really cool. I think it was pretty amazing. We're always trying to think of, and we've got another talk on this in just a minute, something about zebrafish and repairing spinal cords, but we always talk about, how are we going to get the neurons to reconnect again? And what they've done is they've totally circumvented it. The thing that's amazing to me, and again, this is in primates, and I'm not as familiar with their nervous system as humans, but they were able to walk almost the same with the implant being in the right area. So this, thing in the cortex over the motor cortex, which is going to be in the frontal lobe, a little anterior to your central sulcus there, kind of in front of our ear, picked up the motor signals and then, as Sean said, translated it to a computer, which then sends the information back to the lower cord. And the fact that it was able to be that precise and affect the limbs which involve locomotion. Now, the monkeys, and I believe these weren't rhesus monkeys. These are rhesus or macaws. I can't remember. These monkeys are walking in somewhat of a quadrupedal fashion. They're not walking in a bipedal fashion. And that is going to change things because when we put balance in the equation, now we have to bring in the vestibular system, and there's a whole nother root of neurology that needs to be applied to what's going on as well. But it was amazing that the walking was that much more precise. And when you look at the actual footage of it, it's like, wow, that looks pretty close to the way it was before. So pretty neat stuff. And, this will probably be coming to a place near you. And all that stuff they did on Star Trek and some of those other shows probably isn't that far off.
Yeah, the just last weekend on the blog, social media, etc., we put up I kind of revamped and revisited some stuff on crawling and quadruped motor patterns. And as we know, when we start to crawl, we start to access the upper motor neuron pools a little differently in the upper limbs as opposed to when we're just doing bipedal gait and the arms are just swinging. And by using the arms, we actually access some lateral and diagonal patterns in the brain that we don't normally use and that we have suppressed when we went from quadrupedal to bipedal. But nonetheless, as Ivo said, this is pretty amazing. And the idea behind this was that by engaging the brain and the spinal cord together, as they said, we may be able to enhance the growth of the circuits during rehabilitation. And that's one of the major goals of the work in this field in general. So there's a retraining thing there. You hit those circuits enough, you may actually be able to change them. And when we talk about a computer, I mean, that pretty soon we're going to have something as small as, a USB stick or a pencil or an eraser or something. That's the computer we're talking about at some point here. So it'll just be something that you maybe have on your phone or in some kind of a chip that's, strapped to your arm, or maybe even, put underneath the skin. So interesting stuff, but we're getting closer and closer to the Christopher Reeve, wishes that cord transections and spinal cord injuries and quadriplegia are a thing of the past. So
it'll be good when all that's behind us.
Yes, absolutely. And zebrafish and proteins and spinal regeneration, you kind of hinted at it. We're talking about the intriguing protein, the CTGF, connective tissue growth factor protein, secreted in the cells in these zebrafish. And when these guys So the fish, unlike humans, can repair a completely severed spinal cord. And to do that, the disjointed parts of the severed parts create a bridge or cell projections that branch out over large gaps. And the nerve cells then bridge over this gap, causing a repair to the damaged area. And these guys monkeyed around with the CTGF, the connective tissue growth factor code. And when they monkeyed with it, the fish were unable to regenerate. And so the theory is because humans and zebrafish share a protein coding gene, that this may be translatable to humans. So take the last piece that we did about, circumventing the lesion with Wi-Fi, and in the process be healing it with the CTGF protein, and we may have an end to this stuff, completely. The question is how long and how well will this research go? So when's the last time you hunted for zebrafish there, Ivo?
I have to say I really don't know much about zebrafish, so it was kind of interesting to know that, and interesting to hear that they can repair their own neurological tissue. The big problem is if you imagine any nerve or your spinal cord as basically a big cable with a lot of tiny wires on the inside, and if we get severing of that cable, it's getting everything to line back up again when you stick it back together. If the coating or the outside of the cable remains intact and just the wiring on the inside becomes involved, it's a little bit easier because things are in the relative vicinity. But once they've been moved past one another, it makes that task that much more difficult and challenging, so that we can get the right neurons to grow to the right area. And we see this sometimes in people with partial nerve transections and things like that, where they've done nerve repair and they get some aberrant motion occurring within that because the things didn't grow back quite the way that they had hoped that they would grow back, or that they, without as much precision. So this is exciting if something like that could work. And then if you imagine, each cell sort of sending out a little tentacle, each nerve cell, and that connecting on the other side, and then the nerve or the axolemma growing along that to reach the precise one on the opposite side. I mean, gosh, incredible stuff. And then we could take this, this whole thing, like you were saying, circumvent it with Wi-Fi in the meantime, but then also use CRISPR genes to, accelerate or decelerate the process.
Yeah, and this is why we put this neuroscience stuff in here, because it's all gate related, and it's related to things that are sometimes more complex, but things that are going to be coming down the pipeline in the future. But it is really pretty cool, and things that we talked about several years ago already are showing up with advancements. But that's the beauty of science. So in our last podcast, we ran out of time, and you'd wanted to talk about Cadence a little bit, and I think it's really important that we do, because the last time we did it was almost 100 podcasts ago. I looked back, and the last time we did a topic on Cadence was podcast 48. So we are some 70, 80 podcasts down the road now. Probably time to revisit this a little bit, because there's been some new research, but I know you've learned a little bit more. And I had an interesting case. We'll just start off with this, and then we can go into some of the thoughts that you wanted to talk about, and I'll interject as well. But I've got a high-end senior Ironman triathlete in my office, and he's having some glute problems. We're having troubles getting him to refire his hip extension pattern appropriately and get the glute to fire at an appropriate time. And he's having all kinds of problems doing that, getting all kinds of splinting of the deep six rotators, and he's engaging the hamstring too much, and he's inhibiting the abdominals and getting into his low back, and we're having a dickens of a time trying to get him back into some clean patterns after well over a decade of triathlons and beaucoup miles and just ridiculous training miles each week. It's hard to fix something when someone keeps ripping it back off and putting in the old movement pattern in there within a couple hours of your treatment. And he's dosing his homework more. He's been doing better. But what's interesting is that, and this pertains to cadence, is that when he's able to get his cadence at 180 in his running, he can feel the glute work better. As soon as he drops down that cadence to 170 or below, he can't get into the glute, and he dumps back into his old pattern. So it was really proof that, it was time to look back at the cadence literature and dive into it a little bit more and see if there was some factors that we were missing. And so I'm glad that you wanted to talk about this. So why don't you start things off, and then I'll add what little I know.
Well, I'm sure you know a lot. So first of all, why do you think that or what do you think is the reasoning with your patient as far as when he's at a higher cadence, he's able to engage the glute, but at a lesser cadence, he's not able to?
Yeah, well, the logical things are that if his cadence is lower, his step length is a little bit longer, the impact loads are a little bit higher, all of those good things, and all of those things are going to make a longer stride means there's a longer period where the pattern is sitting out there vulnerable. If you're turning things over, the strides are shorter, but the cadence is higher, the foot's on the ground more frequently, and the impact loading is less. And we know that the peak knee flexion and the later occurrence of peak knee flexion and internal rotation change with increased cadence. They work in favor, they decrease. So we know that that's a fact, and those are the things that I'm working on right now. Other than he's probably just a little bit more in control too with a higher cadence, even though you would think that someone isn't, but the steps are a little shorter, and I do think it's a little bit more of a control issue. What do you think? Or maybe I should say coordination, not control, but they are the same thing. And we know that changes in coordination increase with increased cadence, right?
Mm-hmm. Well, a couple things. We know from stuff that we've written on before that as folks run faster, and if step length remains the same, then increased cadence means running faster. If step length remains changeable, and then cadence remains the same, then we can either increase or decrease speed, depending upon what's going on. But as our speed increases, the demand, and we wrote this post a while ago, but the demand on the glutes is much greater. So in other words, they're going to be engaged more. So the neural drive is going to be there as we're at faster speeds. As far as more motor control, I'm not so sure. We get a lot of that cortical fudge factor that we've talked about before when people are going faster and faster and faster. In other words, there's more interpolation done by the brain. In other words, it assumes that this is what's going to happen next and bases its decisions on that assumption, whereas when we go slower, it can't do that. So my guess is with your patient is that, one, he has better engagement at higher because there's just the demand is there. Physiologically, that's how it works. But then number two, as he starts to slow his cadence down a little bit, he's got a cortical issue with integration. And he's not able to do that, and that's why he breaks down. So the brain is obviously concentrating on something else, whether it be his lumbar erectors or his hamstrings or whichever other muscle. But I would think it might be a cortical integration kind of thing that's going on. So my question to you then would be, at this point, are there other areas, say balance, what is his proprioception like? What is his balance and coordination like with his eyes closed? What is he able to accomplish there? And is there potentially an integration issue that's going on there that could be explaining some of this?
Well, there certainly could be. We've been down the road now for several treatments, and we've looked at everything from motor patterns, and I think it's time for me to go back to some more primitive motor patterns to see if some things like just basic stability is there, and I'm talking about core patterns from rolling and turning over and stuff like that, because we've gone down the traditional high percentage items and we've worked on them. He's improved, and don't get me wrong, he has improved with this problem, but it's becoming, I always say this, we get our patients, and we as patients get greedier the better we get. It's not hard to get a C in a class. It's a little easier to get a B, but once you get an A, you got to work that extra little bit to get the A plus. And if you've got an A and you're doing well, but you can see the finish line on the horizon, sometimes getting that last little bit is that extra frustrating little part of extra work that requires a lot of volume of extra work. The difference between A and an A plus is often a lot of memorization and nuanced, nuisance work that requires a ridiculous amount of intensity and concentration. In his case, that's where we're going right now to see. There was the classic stuff. He was having problems engaging the frontal plane, and every time the pelvis drifted over that leg, and he initially had started with some right knee pain, and that's what kind of pushed him over onto this left glute inhibition issue. So he's getting better at finding that stacking of that left leg, and all of those things. But, it's like I said, it's hard to fix somebody when they've got such massive volumes of workouts at different tranches of VO2 max and turnover and cadence and VO2 and everything else, and then you throw them on a bike and you throw them in a pool, and that's a different pattern. Although it's similar, it's not the same. So I just think there's a lot of things here. There's one of the quotes from one of our studies here: coordination variability decreased with an increase in cadence. And that's what we're trying to look at right now, is coordination. And I think that if we can get him a little bit more coordinated in the pattern, and admittedly so, it's probably been only about 2-3 months now, and just a couple treatments in there, giving him some good homework in between. I think it might be a little unrealistic to find a perfect A+ at this point. We've got a high B, low A for sure. But it's frustrating, and these cases are the ones that test you and make you look a little deeper into this stuff. But we're going towards a standing desk. I mean, he's a CEO, vice president, CEO of a company. He sits on his hiney for about 10-12 hours a day. And I said, look, I mean, we're sitting on this thing in a flexed posture all day long. There may be a factor there as well. So we're getting him a standing desk just to take out a little piece of the puzzle that may be a factor or not. But anybody sitting that amount of time should be standing anyway. So it's going to certainly have some advantages on several angles there.
It would be interesting also to look at him run and see, as he changes his cadence, how the position of his head changes.
Sure.
So a lot of times when people increase their cadence, they're going to increase their speed subsequently, have the tendency to flex their cervical spine, not extend, which is one of the things I know that you do with your athletes and we do with ours that are sprinters, is in encouraging them to keep their head up, not down, as they're running forward, because once we start to engage the flexors, we tend to have more of a problem. He kind of seems possibly the opposite, but looking at that head posture during that as well would be an interesting thing to see if how he's doing that, because the upper cervical spine is just such a tremendous amount of input into the vestibular system. Not only vision, but also those upper cervical neuromirrors, feeding right into the cerebellum. That would be a real interesting thing to see as well, and see how that degrades. Or as he goes into a lower cadence, making sure that he extends his head to a greater degree. Just thoughts, random thoughts here.
No, and good thoughts. And probably, if this latest attempt isn't going to get us any further, we're going to probably have to go to those things and start working out the fine-tooth comb on some of these smaller things. So it reminds me of another case that's working its way through our office. A good friend of mine, ACL repair, ligament repair in the knee, and he one of the first that I have heard of, and certainly have ever treated, of an ACL graft where they stitched the graft together around basically a sponge-like material and injected stem cells into the sponge-like material. So he has his own ACL grafted across the ACL rupture, injected with stem cells on several occasions, and rehabbed very quickly. And we've got him to the point now where, and the rehab is quicker because there's no patellar graft, there's no autograft, there's no allograft, there's no cadaver graft, there's no, hamstring transplant. So, there's less parts to fix. And so it's just a matter of letting that ACL heal. It's healed very well. But we're having him, those rope ladders that you put down on the ground. Mm-hmm. We're having him do some ladder skills right now. And it's quite obvious on that leg. We're having him do slow and high tempo foot taps like you'd see in NFL players. They're moving on either side of the ladder and through the ladder, diagonals and side steps, really kind of fast feet type maneuvers across these rope ladders on the floor. And it's quite clear that you can hear how hard he's hitting on the grafted side, which really is a proprioceptive thing. And it takes him a good 10-15 minutes of drills in order to get it a 1-2, 1-2, 1-2, 1-2 instead of a plunking 1 and a 2 and a plunk 2, plunk 2, plunk 2. He's hitting down harder. It's slower off that ACL side. So the higher his cadence goes, the cleaner it is. Obviously, he's not spending as much time on the ground there, but you can not only see it, but you can hear it. And we cued him into hearing it so that he can now feel it. And it was funny. I was over at over at the Gracie Jiu-Jitsu Academy with me, and it's funny that even months down the road, he's still, when he's not paying attention, you will see him limping around, and I'll ask him if he's in pain, and he says, no, not in pain. Why do you ask? And I said, because you're limping again. He's like, oh, not again. So these things do take a lot of time. The brain and these proprioceptive type mechanoreceptor problems are definitely really persistent problems. The ACL is such a huge mechanoreceptor, proprioceptive organ in the lower limb. Perhaps, according to some studies, at least a couple of years ago, one of the most enriched areas for lower limb proprioceptive input. And so when that thing goes, you've taken out a rather huge organ to knowing where the limb is in space. And as we always said, if the brain doesn't know where the thing is in space, it doesn't know how to treat it and move it and coordinate it and control it very well. So that was kind of neat. Increasing cadence improved the deficit. And so once again, coordination, variability, and cadence are a factor. Any thoughts on that one?
Well, it brings me, when you were talking about, doing tap drills and stuff like that, are you using what are you using as a cue? Are you using a metronome or using music? Are you just using his own, regular intrinsic beat,
Yeah, just trying to get him into a consistent, through the whole ladder, forward and back, just a consistent tap, 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 and not this tap, 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 which most people do when they've got an injury, or in this case an ACL. They don't trust that leg, so there's this kind of, you step down on the affected leg, it's a little slower to react, it takes a moment to know where it is in space, and it's what creates that 1-2 variable instead of a just 1-1-1-1-1-1-1. So no, we're not using a metronome. It would be very fast, and frankly, with the foot sounds on the tile, it would be, you probably wouldn't hear it. So,
well, you could use an iPod or his phone. I mean, there's free metronome programs. You'll have a tendency, when you do use a metronome or use something with a steady beat, to create more regularity. The nervous system really likes regularity. One of the pieces that I wrote on the blog, it was more of sort of an essay than anything else, but I was talking about one of my morning runs and listening to music. But I cited a couple papers in there that talks about how music tempo can impact running cadence, and that as you change cadence, as we talked about in other studies, that's going to decrease variability, as well as it's going to decrease impact forces. And you can actually impact people's foot strike patterns by increasing their cadence. You're going to shift them from a heel to a mid or a forefoot strike pattern, depending upon what percentage of increase in cadence that you're using. So, and maybe because I'm a musician, I do this, but I use music or tempo stuff a lot in the office. And we did a series of pieces a long time ago talking about music therapy. And we were talking about, I don't know if you remember those, but there was a series of 3 or 4 that we had written.
Do.
Yeah. And just when you're doing gait retraining, that can be important. And I think sometimes if you can give the system some sort of regularity that it can anchor to, it makes some of the training go a little bit easier. Not that they necessarily have to listen to music, but even if you're just listening to a tap beat or something like that, because it's going to change. As the cadence changes of whatever music you're listening to, it's going to change your cadence, or as the beats per minute changes. And that's why it's important when you're running to maybe, depending upon what you're going for, but maybe have music that has varied tempos on different ones, but understand that the slower stuff is generally going to probably slow you down, because your body's innate instinct is going to be to match that cadence, or speed it up if you're trying to stay at a certain one and you want to go faster, than using something with a little bit of a more driving beat and a higher step rate or beats per minute is going to make a big difference. I haven't
the numbers. What's that?
I was just going to say, I haven't seen any studies on accuracy, and because I just thought of it, but accuracy and like regular tempos. But again, I would assume that if you have something that your system can anchor to, then you can take attention away from one task and put it towards another one. So my guess is that accuracy would be improved, but I would have to go dive into the literature a little bit to figure out if that's actually what the case is or not.
Well, yeah, we did have a study a while back on dual tasking. Well, it was several articles, and that dual tasking We've always talked about parallel processing and dual tasking, and that, the parallel processing seems to be okay, but the dual tasking certainly has its own hazards of reducing cadence and decreasing stride length, decreasing speed of movement, and even in this one study, increasing ankle dorsiflexion. So we know that when there's distractors that we have other issues there. But the numbers on that one study, I thought they were worthy of us sharing here, was that the intent of this one study was to determine whether the step rate manipulation alone was enough to change foot strike pattern in shod recreational distance runners. And the study found that increasing step rate above the runner's preferred rate by 10%, so just 10% above your normal cadence rate, was successful in changing foot strike patterns from a heel strike to a midfoot or forefoot strike pattern in 17.5% of the runners, while increasing step rate by 15% changed the foot strike to 30%. So there's definitely a correlation between step rate manipulation and foot strike patterning. So, if you're having troubles getting out of your heel strike pattern, maybe just try increasing your cadence, and it shows here just 10% will increase it 17%. But if you want a 30% more valid number, just increasing it 15% will get you there. So there's definitely some stuff here on cadence and changing, a lot of that. We've often talked about step width, and usually with increased speed, there's an increase in step width. But as we have discussed well over the last 6 months, there's a lot of variables playing into that, including crossover gait and torsions at the femur and at the tibia and at the talus, and foot posturing and forefoot varus and all kinds of stuff here. So, it's a very complicated task, and a lot of the times just increasing one variable like cadence doesn't actually change a lot of the other mechanical variables that can come into play that may actually be expressed or depressed depending on that cadence. So it gets complicated.
It's always complicated. There's never a simple answer.
Yeah, hey, that reminds me of that quote that I just have fallen in love with from Neil deGrasse Tyson. I'm not sure if you saw that on the blog, but man, talk about smacking me across the face. It's going to be one that I use over and over again. Knowing enough to think you're doing it right, but not enough to know you're doing it wrong. How many times do we watch? I just watched a YouTube video and I put it up on our page, and maybe I shouldn't have, because it was just the softest, most gentlest, kindest, loving spanking of someone putting out a video that just said, wow, I know you're trying to do a good thing there, but I don't think you know enough to know that you're probably doing some things wrong in that video. And all things with good intention, we appreciate that, and we said it very kindly, just saying, think this through, guys. If you've been with us long enough, you probably can put two and two together to determine whether or not this was some good information or not. And it's the great thing about the internet, but it's also the bad thing that if you don't know enough and you go on any page and they've got some advice, it's very easy to take that advice as gospel. And gosh, how many times have we talked about things that are just improper gospel, so.
Well, that's enough on cadence.
Yeah, that's a good little update on cadence stuff here. So this week we did talk about torsions, and it was a great case. I love that case because there's a lot of little pieces going on with that thing. And I followed it up with a post yesterday and today on things to think about. And I think I like the way this thing came out. If a patient comes in with a toed out presentation, where's that coming from? Is it coming from metatarsus abductus? Is it coming from, a talar torsion of the talus? Is it coming from external tibial torsion? Is it femoral retrotorsion? And, the hard part, and we didn't talk about this in the presentation, but the rabbit hole really truly comes out that you usually have multiple things going on, don't you? Like if someone has some retrotorsion, it's quite possible, if not probable, that there's going to be a little bit of a correction to that in the tibia in the opposite direction to try and, nullify that a little bit. And, then there's that at the ankle and then the foot. And sometimes it goes in the other direction and you get a talar torsion and a foot progression angle that then has to be modified, through the growth plates and through the early, decade of life there, where the tibia is making some compensatory changes, hopefully in the right direction, but sometimes it's adaptive, and that's the troublesome part. And then the femur makes it changes, so you get that upward and downward problem there. Would you agree that a lot of the times there's these adaptive things at multiple levels to try and buffer out the extremes?
I agree. It's just not logical the way you would think about it. Like commonly with femoral retrotorsion. Now remember, retrotorsion means that the angle of our femoral head to the femur shaft, looking at it from either superior or inferior. So we're not talking about the coxa vera, coxa valga. We're talking about anti-torsion, retrotorsion. Normally that degree should be between 8 and 12 degrees. Okay, and it's much larger when we are first born, and it's going to steadily decrease at a rate, and sometimes if it doesn't decrease enough, we have femoral anti-torsion, and if it goes too much, we have retrotorsion. Well, that is commonly going to be seen with internal tibial torsion. And those are two that go together constantly. So what does that look like? The person has limited internal rotation of their hip, and they have internal tibial torsion. On the table, their feet kind of point to the inside. And those two things you're going to see together. But when we think about the actual rotation that's occurring, we're going from a relatively anteverted position to a retroverted position. The tibia is rotating in the opposite direction growth-wise. We start, if we look at the transmalleolar axis, the axis between the two malleoli in the lower part of the leg, and we look at the top of the tibia, okay? When we're born, that's 0 degree difference between the two of those, if you take the angle. And then what happens is it's supposed to spin outward 1.5 degrees per year, till we reach skeletal maturity. Sometimes that angle will be less than 0 at birth, and that's usually because one foot's overlying the other in the womb or something like that. But it still rotates outward. So it's supposed to rotate outward. So the femur effectively is rotating in one direction, and the tibia is rotating kind of in the opposite direction with growth. And that's why...
That's
right, and you got to twist your head around like what's happening.
Right. No, so let's just hold. So retrotorsion, for those people out there, these people have a decrease in internal rotation of the femur. So the knee is often rotated out when viewed in a standing position. So this is it's like someone's grabbed onto the knee and someone's grabbed onto the top of the hip, and they've spun that thing. They've twisted it like twisting a towel. That's what this torsion is, for those of you who are kind of new to this stuff. And so in retrotorsion, the knee is rotated outwards relative to the sagittal plane, and they've got decreased internal rotation of the femur. So didn't mean to interrupt you there. I was just trying to give people a better visual in case they don't have a picture in front of them.
No interruption at all. I mean, just that was it's knowing what's happening. And I would really encourage people, we have this stuff on the new webpage, but if you go to the Tumblr blog and you type in torsion, there's a whole series. It's called We're All Twisted, and it's a 4-part series talking about progression angles and different torsions. And we excerpted from, the second edition of our book, whenever that's going to come out at some point in the future, but a portion of one of the chapters that we had put together on this. But looking at this developmentally really makes a huge difference in understanding the ontogeny of how things are supposed to unfold later on. Really helps you see how things can develop, whether into a gait abnormality or whether into a structural abnormality that we see later in life. So femoral retrotorsion has a tendency to go with internal tibial torsion, just like femoral anti-torsion has a tendency to go with external tibial torsion. Now, it doesn't mean they always occur together, because just when you think it's kind of a rule, you're going to meet somebody that is the total fake out. But generalizations, kind of like we use that generalization, for pronation, as far as, generally speaking, when we have a leg length discrepancy, people are generally going to supinate more on the shorter side and generally pronate more on the longer side. But that's not written hard and fast. We see plenty of cases, like the gentleman we talked about the other night, that was pronating way more on the longer side. On the shorter side, due to abnormalities and anatomical constraints that were going on. But understanding that and really delving into that, and here's another one, and then
Hold on. So let me just throw out a little example that will give people. So let's say you have someone lying on a table and you go down, you grab onto their foot and you rotate that foot outwards. So you're putting this kind of if you will think about it, a retrotorsion type torsion into the femur. You're cranking that foot outwards, making them more duck-footed, and that knee is going outwards. That's kind of like a retrotorsion type of thought process, if you will. And so, as Ivo said, that is often met with internal tibial torsion. So let's say you crank that leg out, and now you reach up and you grab onto that knee and hold that knee in place so that you maintain the femoral retrotorsion. And now you go down and grab onto the foot again, and you start spinning it inwards, giving you internal tibial torsion to try and bring that foot back into relatively less of a foot progression angle, or a little bit more sagittal. So that's why you always see, or you often, not always, but it's retrotorsion is quite frequently paired with internal tibial torsion to try and nullify some of that torsion. The problem is you get a knee that's a hinging joint stuck in the middle of all these twisting torsional things, and that's why these people tend to have a lot of problems. And then down at the ankle, you get a lot of these things playing out. And go back to the blog piece that I put up today on the 18th of November, and it's on social media too. And I talked about, look, you got someone who comes into your office and their foot's turned out. What is it? Is it retrotorsion? Is it external tibial torsion? And then I go through a whole cascade of thoughts of, well, if this person is in your CrossFit box, you're training them, and they're doing a squat and the foot's turned out, it would be kind of stupid just to tell them to turn their foot in if you didn't know whether or not they did or did not have retrotorsion or external tibial torsion. Because by changing it because you don't like the way it looks, you could be opening up a whole new can of worms for that client and a lot of pain and problems. So sometimes just because you don't like the way it looks doesn't mean that's what you should do in terms of change.
Piggybacking on that, two things. This is why another reason, or two more reasons, you need to know about things like torsions. So you have an individual in your office that has overpronation for whatever reason, and you want to stick them in an orthotic, and they have internal tibial torsion. Now, people with internal tibial torsion, that means that when the tibia is straight, the foot points to the inside. Okay. In other words, I drop the plumb line down, it falls lateral to the second metatarsal, a lot of times lateral to the foot. So generally, when that person is standing, your brain's not going to let you walk with your toes being dink-toed, or toed in. So what you're going to do is you're going to create external rotation of your lower extremity to at least neutral or a little beyond that. So now where's the knee? It's outside of the sagittal plane. Now if I stick a wedge or an orthotic under that foot, what am I going to do? I'm going to drive the knee further outside the sagittal plane. And the knee, as you've said hundreds of times in podcasts as well as pieces, is basically a hinge joint between two ball and sockets. So now all of a sudden I'm going to ask the knee to work in the sagittal plane when it's off axis from the sagittal plane right now. And who's in the middle there? The meniscus. And what are you going to end up doing? Hurting the meniscus. Okay? So people with internal tibial torsion, we're not saying don't put them in an orthotic, but you're going to have to make sure that orthotic is appropriately posted in the forefoot. So as they come through mid-stance, you're going to drive them back onto their big toe, or their knee's going to be too far outside the sagittal plane. Taking that a step further, let's say you have an individual who's right-handed, who's golfing, and looking at their foot stance. Now, if we golf, if we're a right-handed golfer, we wind up turning to the right, and then we follow through as we're coming to the left. As my torso follows through coming to the left, I'm causing internal rotation of my left lower extremity and my left hip. If I have limited internal rotation of my hip, and I reach the end point of that range of motion as I'm coming through my stroke, there's no more motion that can occur in that lower extremity or hip, so it has to move north. Where does it move? To the lumbar spine. But the lumbar spine, the lumbar spine only has 5 degrees of rotation between L1 and L5, with most of it occurring at L5S1. So now where does it have to occur? The thoracolumbar junction. So now all of a sudden you've got a golfer with low back pain, okay, because of the way his feet are standing. So if you were to just change his foot position then and had him externally rotate his foot slightly, a few degrees, 10 degrees, as he comes through his stroke, now you've created that 4 to 6 degrees of internal rotation that you need as you come through your stroke. But if you didn't know about torsions, you'd kind of be scratching your head, right? So,
absolutely.
Yeah, and this is stuff that we see all the time. Sean and I, like, he'll come up with something, and then all of a sudden I'm like, oh my gosh, that's brilliant. I hadn't thought of that. And then it goes back and forth. But that's why we hammer on torsions and versions so much. And I've seen post after post that Sean's done about people that are CrossFitters or people that are doing squats telling you simple thing. Oh, well, put your foot out, put your foot down, raise up your heel, raise up your toes. What's the answer? It depends.
Or make sure your knee's going over your foot.
Right. It depends. It depends. What's your anatomy? There's going to be a best scenario for each person, but that's going to be individual. We can't genericize.
Yeah, and it's natural to want to simplify things, folks. It really is, but this is not something you can simplify. And let me complicate it further. You have these people, and I call them smart bodies and dumb bodies just because it tends to raise an eyebrow with people. You have clients who will fall into a deformity because of weakness and unawareness. And then you will have people that have the awareness and have some strength, and they compensate in the other direction. It's like someone who's got a real flat foot and they know they pronate, but they've got a pronation problem, but they stand on the outside of their foot all the time because they know that collapsing inwards causes them knee pain. Whereas some people just come in and they collapse and they have knee pain. And they're like, why do I have knee pain? Well, it's because my foot's collapsing, but they're not aware of that component. So you get the people who are good compensators and you get the people who are bad compensators, or what I say, non-compensators. So you have to understand that you've got these different types of neurologic processed bodies out there, and then you add all this torsional hardware on them, and then you add a software that says, well, we're trying to figure out where to put this load because we can't put it at the into the quad, so let's throw it up into the hip somewhere. And so now someone comes in with hip impingement because they've got a torsional disorder in the femur, which is compensated at the tibia, but they don't have enough internal hip rotation, and so they're trying to get it through more foot pronation, which gives them the hip pain. So it's this really complicated, muddied thing, and it just drives me nuts when people just look for weak muscles and treat that, or they just slap an orthotic in because they don't like the way the foot looks, or let's modify your squatting technique or your deadlift technique because we don't like the way it looks, and people come in with back pain or hip pain, or it's so. I mean, I'm sure you are the same way. I wish this was a lot easier a game to play, but it's just not. And so because it's not an easy game, you can either pretend that you know what you're doing and be very aware, like in that quote that I made or I gave by Neil, but knowing that you probably don't know nearly enough in order to be as certain as you probably are. So it's about going back to school, and it's why I love talking with you and teaching those classes and having these discussions, because every time you grasp a little more, so you go a little deeper, you understand the principles a little bit more. And I'll be honest, this morning, writing that blog post, I got up at about 5 o'clock, and I thought, I'll pound this out in about 10 minutes. Of course, I had 3 textbooks open and 2 journal articles over on PubMed, and I'm reading about it, going further down the rabbit hole, realizing, oh shoot, I didn't know that polio and cerebral palsy and these types of things were factors for in-toeing gait, and that it correlates with adductor metatarsus adductus. And I'm thinking, whoa, okay, let's go back to school here a little bit. Maybe I'm not even smart enough to write this blog post, but I'm going to give it a shot. So just keep reading, guys. Keep learning. Hang out with us. We're trying our best. We get stuff wrong. And call us out when we do, because that's where we all learn. So
it's all good stuff. I would really encourage you, go in and read more on torsions and versions. Go back, and we've got lots and lots of posts talking about this, lots and lots of instructionals. And then, go online, do some searches. Go to, Google or whatever your favorite search engine is, click on images and type in internal tibial torsion and look at a bunch of pictures. Now, remember, if you see a lot of pictures looking one way and one looking another way, there are, believe it or not, mistakes on the internet and incorrect information. So you might have to say, this one might not be. We've blatantly seen things labeled absolutely wrong. It's like, oh my gosh, that's terrible. And, sometimes in people's defense, we'll put something up in a post and we'll have a typo or we say right when we meant left or something like that. That happens as well. Yep. But take a look at some of these things so you can actually start to understand. And I'm not aware of a lot of literature out there that talks about this stuff's impact on the gait cycle. Other than
no, I think that we are one of the few doing it.
Yeah.
And one question we always get before we close shop here is that always whenever we do torsional stuff, whether it's femur or tibia or talar, inevitably someone asks, how do I correct this on my client? And the answer is you don't correct it. It is an osseous bony deformity that cannot be changed unless you are going to actually send them off and have them to have a derotation surgery with pins and screws, and which we don't recommend. But what you can do, for example, in retrotorsion, these people have problems with limited internal rotation at the hip. You may look and say, well, I can actually improve the armor or the strength of the skill and endurance of some of the muscles that help with that, like the vastus lateralis or the TFL IT band or anterior glute medius. Find the muscles that help with more internal rotation because they don't have it because they're stuck in such excessive external rotation. So that's when you can start to say, well, I can actually train you a little bit better to help you adapt to some of these osseous, bony changes that are giving you some limitations. And sometimes it actually helps the range, but sometimes it's just protection from the functional pathology that ensues from having those osseous deformities. So keep in mind that there's a lot of things that you have available, and the more you understand it, the more you'll know which muscles then probably need a little bit more attention to try and buffer that. Because as Ivo likes to say, if you don't have the rotation in one place, it's going to go somewhere else. So you better teach their system how to adapt to it and how to manage it. Otherwise, that rotation issue, if that's what it is going to play out at that next proximal or distal joint and could in itself create pathology because you can't control it. So the body's going to put it somewhere. Do you have the right shoe? Do you have the right mechanics? Do you have the right awareness and skill, endurance, and strength, as we always say, combined with power and stuff like that to survive it over and over again, repetitive loading until tissue tolerances run dry. So, whew.
Amen.
That was heavy stuff, yes. Praise Odin. Yes. All right. Well, I'm exhausted.
You're exhausted.
But this is good stuff.
I got to get a workout in, man.
Yeah, I know. I just got back from jiu-jitsu, and this is I did my physical chess. Now I just did some mental chess with the neuro guru himself.
Oh, I don't know about that. So,
anyways, yeah. Well, we wanted to thank our sponsors always, ultrarunning.com. Try out their new desert boot. I'm still loving mine in the office. If you want something a little lower profile, go into the Ultra every day. They've got some awesome shoes. Ivan and I talked about the new Lone Peak trail boots. Boy, snag a pair of those into the fall weather here. You're going to love your trail runs and may actually get hooked on that. And then we've got our tried and true sponsor, New Balance Chicago. All kinds of new stuff. Try out the new, I think it's called the Vazi, the new 4mm shoe that they've got out there. They've got some fantastic stuff. I just love New Balance. They've come up with some new lines of stuff that's just absolutely gorgeous and beautiful. And I'm going to be heading over to that store on the weekend here and see if I can scoop up a pair of some of their new trail shoes. So thanks for our sponsors, and thank you, Mr. Ivo. We had a busy week teaching and this and a bunch of other stuff. So thanks for your time, buddy. And so, I'm Sean Allen in Chicago.
Ivo Whirl up in Dillon, Colorado. We'll see you in the shoe aisle.